Welcome, Mr. Cuthbert. Welcome. Is that New York City that you are in?
Good morning. Can you hear me okay?
Yes,
yeah?
Loud and clear.
Good. So actually, I am with you from Madison, Wisconsin.
Wisconsin.
And just happens to be a map behind me, and I'm right there. I had a little orange sticker for you, but it fell off. But just wanted to show you. So good morning. I'm very pleased
maybe
to
you
be
can
with you.
point. Maybe you can point at the map where you are right now.
Yes, the pointer is not working yet.
Yeah, but your finger is.
There.
Nice. Yes, good.
It's hard to find in the camera.
And how are you? How are things over there?
Very well, thank you. We are proceeding with all safety and caution, as everyone.
Yeah.
And so it's very well, thank you. I was actually in Amsterdam right when the virus was starting. The first case was diagnosed in Amsterdam while I was there. So I know that it's affecting all the world, and I hope it's also well with you.
Yes. We're in good health here in the studio, and so this is the reason why we talk to you online. Hilko will introduce you, and then we would love to hear your speech. Yes?
Of course.
Okay.
Well, Dr. Cuthbert, we're very happy that you sticked onto our program. We invited you 3 times now through all the delays, and as I already explained to the audience, because of time differences, you're now scheduled in the afternoon whilst being our main plenary speaker. And let me introduce you to the audience for those of you who don't know you. You're a fellow of the American Association of Psychological Science and a past president of the Society of Psychophysiological Research, and a holder of many other positions and chairs. But I think for this talk, one of your main assets is that you've been the director and actually also the founder of the research domain criteria RDoC framework or research project of the NIMH, which started, I believe, in 2009. And I think through this system in which you develop more a dimensional approach of behavior and neural systems, which I think you will address in your talk extensively, I think you are one of the leaders to really start the philosophy of more precision psychiatries and precision therapies, and one of the leaders of our field, I think, to get beyond polarization and to really show how we can deal with complexity and through integration and synergy of disciplines. So I think your importance cannot be underestimated, and we're extremely honored to have you as our main plenary speaker in this year's conference with the theme of precision psychiatry.
Well, that's your cue, Mr. Cuthbert. Go ahead, please.
Okay, thank you so much. Yeah. I'll share my screen here and start the slideshow. There. Can you see that okay?
Yes.
Okay. So first of all, before I start, I'd like to say thank you for that very gracious introduction. And I would only say that while I am grateful and appreciative that you have described me as the main plenary speaker, I would have to say that I want to share that role 50-50 with Quentin Huiz, my friend and colleague. That was an excellent talk, and in no small part, that's because the work that he does so much exemplifies what we are doing with the research domain criteria approach. And I'm so happy that he gave this talk before me, because it really gives examples of the kinds of approaches we are doing, and I hope you will think about that during my remarks, and I'll get started with that now. Like Dr. Huiz, I'm going to sort of take a large 30,000 meter perspective on this without getting into too much details with the time we have. And so let me just jump right into sort of the perspective of why we are doing the research domain criteria, or RDoC as we call it for short. Just to go back, our first systematic clinical descriptions and analyses of mental disorders came in the 19th century from psychiatrists who were termed alienists due to the experiences of patients being just so completely different from normal. And certainly these seemed like clearly disorders with these very florid psychotic symptoms that people would see. And as we know, Kraepelin and Bleuler were some who did the first systematic descriptions of our disorders. And like most of the areas in the 19th century, in this area of medicine, they defined disorders on the basis of symptoms and signs in the course of illness. And like other areas, they assumed the existence of very complex but yet very specific diseases on the basis of symptoms. So for instance, Kraepelin termed mental disorders as natural disease units, or natuurlijk Krankheitseinheit. And you can see Stefan Hecker's nice review about that. And so that's sort of where things were. And if we fast forward to some 140, 120 years, we've seen that now as we come into the modern eras of science, this is not working so well. And so RDoC really came into play, looking to address these problems with diagnosis. So we now know that things haven't really changed that much in many ways. Unlike the rest of medicine that has moved on, our current diagnostic systems and the names of our disorders remain based fundamentally on clinical symptoms and signs. And we know that these disorders were devised more for reliability rather than validity. And we can think of these now as broad syndromes, not as specific natural disease units. They are beset by heterogeneity, meaning, as Dr. Huiz showed, that a given disorder can have many different mechanisms, much individual differences among the patients. We also see comorbidity, which suggests that there are common mechanisms across multiple disorders. We see not otherwise specified disorders and so forth. We also know that disorders are dimensional, not a binary healthy, sick sort of thing, but yet we don't have a way to think about that very carefully. And we haven't been able to establish biomarkers very well. Now, all this would be not so much a problem if we could do alternative research, but across time, the diagnostic categories have come to drive the entire research and clinical systems efforts, as you see there. And so that's constrained us from moving ahead. We also have these problems with our patients. The patients get multiple diagnoses and the providers can't seem to agree. Information about prognosis is modest. Treatments are trial and error. And distress may, for instance, be a very major symptom, but it's not constant. It can vary from day to day or hour to hour. And so how do we understand that? And it's hard to decide when we should actually end treatment and to say that, okay, this patient is now in relapse or remission. And again, Dr. Huiz had some very nice data about the difficult issues with risk for relapse and so forth. So overall, the bottom line is that we are really failing to reduce the burden of mental disorders for our patients, both from scientific views and certainly from the view of our patients. So to move forward, what have we learned since then that we could really apply to mental disorders? If we started with a clean sheet of paper, well, for one thing, we know that our disorders reflect neurodevelopmental trajectories, and somewhere around 70% of our patients show significant symptoms, if not outright disorder, by late adolescence. We also know that there are strong interactions with the environment, both for good effects and bad effects. We know that psychopathology is dimensional, and I should say here, not just dimensional within the range of disorders, but really we can see trends or risks for psychopathology in people that we would describe as sort of normal, non-clinical, but then we have risks and increasing severity across disorders. So, for instance, I very much appreciate the work of Jim Van Os in the Netherlands looking at dimensions across psychotic disorders, and his reports of earlier findings that something like 70% of people with a psychotic disorder do not actually have schizophrenia as such. And again, to pick up on Dr. Huiz's talk, we can measure different things. We have psychological measures, biological measures, self-report measures, behavioral measures, and as he noted, these things don't always go together very well, and we don't understand that. And so we really need to measure and relate all these aspects to try to achieve some better understanding of how all these fit together. So RDoC is really intended to move towards precision diagnosis, treatment, and prevention. And for a long-term goal, we want to move away from one-size-fits-all diagnosis and towards dimensional and transdiagnostic mechanisms. I think it's important to say a few things about our strategic principles. We're trying to invert the usual clinical paradigm that we've traditionally had. Rather than looking at psychopathology, to say that we actually want to consider psychopathology as deviations from normal processes, rather than starting with disease state definitions and then looking for biological or psychological abnormalities. And so this really reflects a direct translation of what we know about normal processes and behavior to psychopathology. Again, we want to look at these normal to abnormal dimensions, and we can study these transitions to psychopathology along some factor from normal range behavior into varying degrees of abnormality. And this can inform early intervention in a quantitative manner. Similarly, the idea here is to rather look at diseases than what is this translation? Well, we want to look at functional constructs defined on a data-driven basis, looking at constructs that are jointly defined by behavior or cognitive processes and a neural circuit or system that implements these processes. And one reason for this is actually directly to address mind-body problems, because we're saying for one construct, we want to think about what is the psychological or functional aspect and how is this tied to some implementing neural system. And again, with the kinds of models that Dr. Hui showed, say with the Schultz work on reward systems error and predictions and how people behave, this is just an excellent example of what we're talking about. And finally, again, we are putting a very strong emphasis in computational neuroscience approaches, both for these basic functional constructs and for clinical phenotypes. And so I'm just so glad that Dr. Buse spoke before me, because I don't have time to address that much today, but this is very much the priority for where we are going in the future. So our principles are a framework for studying psychopathology based on dimensions of behavior and neurological measures. And the goals are to investigate these fundamental components that may span multiple disorders, as you see there, to determine this full range of variation from normal to varying degrees of abnormality, to integrate across all these various measures, as you see there, and to develop reliable and valid measures of these components, which in many cases we don't have and we're still delivering. And so another way to put this is that we're encouraging people to look at new ways of forming groups. That is, our groups for analyses are not necessarily disease disorders like depression or schizophrenia, but rather we might group patients across diagnoses on the basis of biological responses, behavioral responses, etc. And I'll show you a little bit of that shortly. And again, our approach here is one of humility. We don't think we've figured everything out. It's just the opposite. We really know that we aren't reducing the burden of suffering, and we need to start off in a new direction, and we're not quite sure what that is, but this is one approach. So our framework overall is to look at these dimensions of considering lifespan development, starting with in gestation, and then we have the effects of the environment acting at different points in development, and only within these important contexts of developmental trajectories and environment can we look at these constructs as measured across different ways that we call units of analysis or multiple units of measurement. So our constructs actually and domains include these domains you see here, and these are domains of functioning, negative valence, positive valence, cognitive systems, and so forth. And then within those, we can think about a construct like cognitive control. And then we have these various units of analysis. And these aren't fixed. They are sort of examples of the kinds of measures we look at, ranging from, I hope you can see my pointer in the screen, from genetics to molecular cellular processes, measures of brain circuitry, self-reports, questionnaires, and so forth, and actual behavior. And so within the domains and the matrix, we actually have the specific constructs that are those based on particular aspects of functioning and their implementing circuits. So for instance, as you see in the left, for cognitive systems, we have constructs of attention, perception, cognitive control, and so forth. And again, these are examples. This is not a fixed set. These are simply ones for which to date we have particularly good data. But the whole point is to encourage people to come up with new measures and new constructs to expand the way we think about behavior and disorders. And again, to follow up with that example, here is cognitive control again with the units of analysis. And the arrows there show you how we might, say, select particular units of analysis in any given study to try to interrelate these measures with respect to a construct like cognitive control. And the equation there, again, just is shown to indicate the idea that we are trying to approach this in a computational way. So I'm going to skip over this very quickly, but just to say that with respect to dimensionality, we really have ways of thinking about this. The traditional way, one way in an epidemiological study, is a case control design, which is what represents what we might say a distribution of, say, phenotypic scores or polygenic risk scores. For laboratory studies, we often have extreme selections, as you see. But where we're really trying to go is with quantitative measures, such as those in the upper right, where each participant is assigned an individual score, and so we can look at this on a more quantitative basis. This is a paper from Plomin's group in the UK. So people might think, well, how does that work? We still have to define categories for treatment. Certainly that's true. But if you look at this distribution, we can think of, say, the right-hand side of this graph as fairly healthy people, risk in the yellow, and then our traditional disorder definitions in red. But we can superimpose on this distribution cut points where we might define, say, mild, moderate, and severe levels of disorder. And this is analogous something to, say, like blood pressure. And this is to say that a dimensional approach does not necessarily mean it's perfectly linear. There can be sort of breakpoints, as with failure mode analyses, to help us actually understand when people really have and experience a sharp decrease in their functioning. So I just want to show you a couple of examples to show how this can work. First, from anxiety disorders. This is a set of paper data from the Lang group in Florida. And these are patients from essentially all anxiety disorders, specific phobia, simple phobia, generalized anxiety, and so forth. And this comes from a measure of emotional challenge when people are imagining their own fearsome situations and psychophysiological measures are taken. And this is a case, again, where instead of looking at specific disorders, the investigators pooled all the data and all the patients and created independent variables by looking at the combined amount of fear potentiated startle to these measures and the heart rate reactions to these emotional challenges, and grouped them into people who had 5 levels of very high reactivity to actually blunted reactivity, hyperreactors to hyporeactors. And that's the independent variable. And when they related these independent variables to different other measures, they had interesting findings. And again, this is a matter of trying to relate different measures. We actually found, or the investigators found, that the hyperreactors actually were those who showed the lowest amounts of negative activity in things like Beck depression scores, anxiety and distress measures, and that the patients with hyporeactivity who responded the least had the highest amount of negative activity. And also, this shows that for functional impairment, we see the same inverse relationship. You might think that those who responded the most would be, and physiologically, would be those with the most severe disruptions, but it's just the opposite, actually, that the hyporeactors are the ones who had the most functional impairment. And you could say, well, how does this fit into diagnosis? Well, it turns out that the hyperreactors are primarily comprised with people who have circumscribed fear disorders like specific phobia or specific social phobia, whereas the hyporeactors are patients who have more broad anxious misery disorders like generalized anxiety disorders or actual depression. And so this gives you a way of looking at these things in a more systematic way. And here, in an even more computational approach, is what is called the B Snip study, and some of you may be familiar with this, in which the investigators sampled a large sample of hundreds of patients with schizophrenia, schizoaffective disorder, or psychotic bipolar disorder, and finding relatively little useful differences among the disorders, as we've seen before, they lumped all the patients into a single psychosis group and looked at a large variety of measures. And in the analysis, they had 2, one a behavioral measure, cognitive control, and 2, a physiological measure of reactivity to sensory motor stimuli, just as normal lights and tones. And on the basis of combining dimensional performance of these 2 classes of measures, they were able to do a cluster analysis that showed 3 different biotypes of patients who varied on their reactivity across these 2 measures. And these data have been very productive, both in thinking about alternative ways of understanding psychopathology, but also in terms of sort of showing an example of how we might approach these data. And we've seen many other biotype kinds of analyses since then. And this is, again, moving forward with these transdiagnostic kinds of concepts. So I wanted to say a word about how this could go towards actual trials and how we actually study our patients. And the idea here is that for clinical trials, in a sort of RDoC perspective, the idea is to go towards more a precision medicine approach, where for clinical trials, what we really emphasize is that to know that our treatment, whether that's a pharmaceutical agent or behavioral therapy, whatever, actually engages the target to which it's intended. And so that we know that we're actually having an effect on the specific biological or psychological target that we want to address. So the idea is that you enroll patients not simply because they have a particular diagnosis, but because they have a measurable impairment in some specific aspect of functioning, for instance, high or maybe low fear reactivity, a working memory deficit, a problem with showing effort. Again, Dr. Ruiz looked at that, and often these are transdiagnostic. And so the outcome measures often are based on change in these particular functions rather than simply overall symptom change for the diagnosis as a whole. And this helps us, in turn, put a bigger emphasis on quantifiable functioning as opposed to simply self-reports. Not that self-reports are not important, but it's also really important to see how patients are actually functioning. And already we've seen examples of these. For instance, the EMA and the FDA, the regulatory agencies, are considering cognition as an indication in depression, as with vortioxetine recently. And this follows the same idea for matrix and schizophrenia. And so the regulatory agencies are also moving towards these functional areas of indications rather than simply disorders. And so here's an example of one recent trial that came out along this model. It's called the FAST MASS study. It was supported by NIMH, and the FAST means fast fail analyses, and MASS is a short for mood anxiety spectrum analyses. And this is to study the effects of a kappa opioid blocker on anhedonia. And we know that kappa opioids actually, those receptors have a function of actually increasing distress in most patients. And so if we block the kappa opioid receptor, that would imply that we might actually reduce their distress and unpleasantness and anhedonia. And so the sample was taken not on the basis simply of depressed patients, but actually patients across the mood and anxiety spectrum who showed high scores on the Snaith-Hamilton anhedonia scale. And the idea of the trial was simply not to do, okay, we do this and then patients report being less anxious or depressed. It's actually that they show a change in physiological response during the drug. And this graph here shows that the activation in the ventral striatum, and it shows that at baseline, both the patients on the drug, which is from J&J, and a placebo group were identical on that VS activation. But after treatment, you can see that the patients actually increased ventral striatal activation, while controls were much different. And this in part shows that the placebo group shows that when you give repeated measures, patients tend to show some habituation and you don't see as much activation. So overall, accounting for that, you see this significant effect. And that over time, there's a strong trend for patients to report lower anhedonia scores across 8 weeks. So that just shows you the kinds of clinical trials that we could look to for the future. So with apologies for how quickly I've had to go through this, the summary would be that we're trying to work towards a paradigm shift, to go from one-size-fits-all approaches to tailored precision interventions. And this involves an understanding to shift the discovery paradigm towards diagnostic concepts that are based on relationships among neural systems, behavior and cognition, and symptoms. Changes in how we think about diagnosis and treatment, away from broad syndromal treatments towards specific interventions. Even though that we certainly are agnostic to these ideas and we want to look at different aspects, we will still look at actually overall disorders where they are useful, but for now we are studying sort of all comers to get a better idea of how we can look at these transdiagnostic interventions. We also have the opportunity to preempt disorder, so changing from managing symptoms in patients who've already been diagnosed to using these measures to actually prevent or preempt psychopathology. And finally, in the future, we want to conduct research that can actually support clinical services delivery through these computational neuroscience methods and applying big data approaches for models of brain behavior relationships and classification algorithms. So thank you, and I'll look forward to a few questions and comments.
Thank you so much, Mr. Cuthbert, and thank you for keeping your own time. I heard a little alarm clock there, right?
Yeah, sorry about that.
No, lovely, lovely. That makes the online presentation so very special coming from the home. There were many questions from our participants throughout the country, so let's give them a try.
Yeah, thank you for this extremely nice and concise and inspiring overview. It's very thought-provoking, as I can see from the audience questions. The first one that we picked out is from a former professor in the Netherlands, Professor Hengeveld. And he wonders why only objective behavior, between brackets, as your focus, why you're focusing on objective behavior, as most psychiatric symptoms are not observable but experienced by the patients. And he quotes Jasper's phenomenology to underpin that quote.
Yes, that is a good question. And again, it indicates the fact that patients' subjective symptoms do not always align perfectly with their function. We certainly care about symptoms. That's why patients come to the clinic. But often symptoms can change from day to day, as I mentioned. And it's hard to know exactly what a symptom means. The patients have to express those symptoms in terms of their own experience. And sometimes it's hard to relate that, to put that into any kind of framework about how we understand what's going on. And so I think this is what has led to the mind-body problems, that people come in and say, I'm very distressed, or I'm hearing voices, I have this problem, and we try to understand that and say, well, there must be a biology for that because it's a mental disorder, so we expect that to correspond one-to-one to biology. Yeah. And it would be nice if it were that simple, but it's not. And so we have to look at these analyses that integrate across all these different levels. Just as you saw in the anxiety disorders data, where the patients who had reported more distress, we might assume were very reactive biologically, but actually it was just the opposite. And so those are the kinds of analyses we need to do to try to put the whole set of information together to come up with better, more precise analyses.
Precision.
Because maybe in simpler terms you're referring to that sometimes diametrical mechanisms might cause the same subjective symptoms?
Sometimes, and other times not. Again, it's the individual differences that we have to look at.
Yeah.
Back to the individual.
Yeah.
So there's one more, I think. We have time for one more question.
So one question I think is, I think there's somebody's more, it's Rutger Goedkoop. He wonders, because there are many similar frameworks. RDoC is a very strong one and a very long-lasting one, but he refers to, for instance, another system of taxonomy, the HITOP, hierarchical taxonomy of psychopathology. And I think what he's alluding to, there's many different of these efforts, and how can we actually differentiate them, or how should we combine them if we, for instance, want to get to more clinical implementation of these novel dimensional frameworks?
It's a good question, and we consider RDoC to be one particular approach in these directions. HITOP is another, and there are others as well. We are actually all working together. There was a conference in Amsterdam just a couple months ago on this very topic, and we are in very close communication with the HITOP people. We feel that all these different approaches all have something to contribute, and again, keeping in touch and putting them all together will help us move forward more rapidly. Yeah,
because I was actually struck by a remark in this sense in your interview that you gave for our national De Psychiater, the Psychiatrist magazine, that you said very explicitly that the RDoC is not ready for clinical implementation for precision psychiatry, that we're not there yet. But still, if I hear you talk, there's so many important implications already being found. How do you want to push them towards that we really are going to use them, for instance, for therapy development?
It's a very good question. What we're trying to communicate is that RDoC as a concept is not ready to be a diagnostic manual like the DSM or the ICD. But that said, clearly as from the FAST-MAS study, these ideas are starting to spill out into the clinical arenas, and because there is such a strong need for new treatments and approaches that are more effective, we have started to fund trials and to think about how these kinds of clinical concepts could actually be applied in the clinic. And that's really one way of working towards a manual, to say, if we try to do a clinical trial with some of these concepts, does it work? And how can we work through all the problems and hurdles that one always experiences with a new concept, that it still has this promise.
Yeah, very good answer. Thank you very much.
Thank you so much for your time, and thank you, question askers. We really appreciate your contribution. And Hilgo told me before that you are skeptical yet very inspiring, and I agree now. So thank you so much.
Thank you so much. It's a pleasure
all the
to be
best
with
to
you.
And stay healthy, and we'll meet again somewhere live, we hope. Yeah?
I know we will. Thank you, and all to you.
Bye, Wisconsin.
Thank you very much.
Thank you.
Bye-bye.
Bye-bye.